Hello and welcome to my audio medical basics, where I read medical books to your ears when your hands are too busy to hold a book. If you like, please don't forget to like, share, and subscribe. Let's continue reading from my case files book collection. Today we'll continue with the emergency medicine case file book. For our third case, a case of anaphylaxis. Today I'll be reading the long case also because the summary is very well summarized. So, a 35-year-old man is brought to the emergency department by ambulance after collapsing at home. He had been feeling ill and took some medicine for infection. Paramedics report field vital signs remarkable for a blood pressure of 70/30 mm mercury, heart rate of 140 beats per minute, respiratory rate of 40 breaths per minute, and an oxygen saturation of 76%. Intravenous fluids and oxygen were administered during transport. Becoming increasingly lethargic, the patient required bag valve masked ventilation by the medics. As the paramedics transferred the patient over to the emergency department gurney, a blister pack of penicillin falls out of the blanket. So the patient was using penicillin. On physical examination, the patient is obtunded with perioral cyanosis and labored breathing. Lung examination reveals poor air movement, and his skin is cool and clammy with diffuse large urticarial lesions. So the questions are, what are the next steps and what are the treatments? What treatments should be instituted? So, summary of the case. This is a patient with a systemic allergic reaction, most likely to the penicillin. The patient's cardiovascular instability categorizes him at the most extreme end of the spectrum of allergic responses, better known as anaphylaxis. So the next step, resuscitation and stabilization should be the focus. Airway, breathing, and circulation should be managed appropriately and in that order, which will mean both procedural and pharmacological intervention. A definitive airway will need to be immediately established in the face of impending airway obstruction, and the patient's cardiovascular compromise must be supported with epinephrine. So that was the next step. What are the further treatments to be instituted? In addition to airway management and early administration of epinephrine, pharmacological therapy is tailored to the other widespread manifestations of the anaphylactic response. Those include volume resuscitation with crystalloid, nebulized beta agonists for wheezing, nebulized racemic epinephrine to decrease laryngeal edema, systemic steroids, antihistamines including H2 blockers, and removal of any remaining antigen such as a bee stinger in a bee sting case. So analysis. Objectives of the case. Recognize the characteristic clinical features of anaphylaxis and anaphylactoid reactions. Understand the underlying pathophysiology of anaphylaxis. Become familiar with the available treatment option and how to implement them. Considerations. This young man is brought into the emergency department with swelling of the tongue and itching. The perioral cyanosis, diffuse wheezing, stridor, and struggle to breathe all indicate impending respiratory failure. A delay of even a minute may be life-threatening, and the most important intervention for this individual is securing an airway. This patient likely has an edema of the pharynx and larynx, and his life likely depends on a successful airway management, possibly requiring an emergency department cricothyroidotomy in the emergency department setting. cricothyroidotomy. Intubation or tracheostomy may be technically very difficult in this patient, but surgical airway equipment should be available. Intravenous access with administration of epinephrine is the most important pharmacological intervention. This patient's clinical presentation is classic for anaphylaxis, and indeed, penicillin is one of the most common pharmacological agents to be implicated. Identification of the inciting agent is not essential for treatment of anaphylaxis, but is helpful in preventing further exposure and recurrence of symptoms. Treatment of anaphylaxis is supportive and requires knowledge of general resuscitative techniques, airway management, and some basic pharmacology. So, approach to anaphylaxis. True anaphylaxis is a type 1 hypersensitivity reaction occurring after a previous sensitizing exposure. In its purest form, this means an immune-mediated activation of basophils and mast cells with subsequent release of prostaglandins, leukotrienes, and histamine. From a clinical standpoint, an anaphylactoid reaction also includes release of these compounds but through non-immune mediated pathway. The only clinical significance of this difference is that anaphylactoid reactions can occur without prior sensitization. Regardless of the underlying mechanism, their effects are similar, and early recognition will determine successful clinical management in these patients. So the only clinical significance of the difference is that anaphylactoid reactions can occur without prior sensitization. Clinical approach. Pathophysiology. When first exposed to a substance, binding antibodies trigger class switching and regulatory changes in gene expression, effectively priming the immune system for its next encounter with the offending agent. In certain cases, this leads to immunoglobulin E binding mast cells and basophils. In the classically defined anaphylactic reaction, the antigen again encounters the immune system, binds to the IgE on the mast cells and basophils, and releases a flood of cytokines that set the clinical response in motion. In an anaphylactoid reaction, the antigen causes direct release of cytokines by mast cells and basophils without need for prior sensitization. In both cases, the end result is the same and clinically indistinguishable. The early stages of some anaphylactic reactions involve increased secretion by mucous membranes. In addition to watery eyes and rhinorrhea, increased bronchial secretions and increased smooth muscle tone cause wheezing and increase the work of breathing. Decreased vascular tone and increased capillary permeability lead to cardiovascular compromise and hypotension. Other cytokines, specifically histamine, can cause urticaria and angioedema. There are numerous cytokines involved in the immunologic cascade following exposure, but no one major substance is felt to be primarily responsible. Leukotriene C4, prostaglandin D2, histamine, and tryptase are known key components in the reaction. Okay, I guess this will be all for part 1 about the case about the anaphylactic reaction, and we will continue inshallah in part 2. Thank you very much for listening, and please stay tuned and pay close attention.